And so when you look at PEF, when you look at radio frequency, when you look at cryo, it's really interesting because the PEF really stimulates a pro-inflammatory, interferon gamma, interleukin 12. It does some interleukin 6, like the cryo, but the cryo doesn't do as much as the PEF. And what's really interesting in this research in 2024 is in the murine mouse model, the radiofrequency ablation induced significant IL-10 and TGF-beta.
Yeah.
This is your wheelhouse right there.
Yeah.
Okay.
Yeah.
So explain to the listeners and viewers, what the heck are these cytokines and those different ones that I mentioned there? And why is it important that PEF did really well in one area and radiofrequency didn't, that cryo is just right in the middle?
Yeah, it's super important because really, one of the things what you want to do is you want to kill something, but you don't want to stimulate the TGF-beta. TGF-beta will be immune suppressive. And so we do know, and obviously we address this when we treat patients, we block TGF-beta.
We do.
Other people don't do that because they don't have that ability, but we do. And it's super important. But, you got to knock down TGF-beta because you're going to get a response. You get this damage. Some of it may be sending these, good signals to the immune system, but some of it may be sending signals that say, hey, this is damaged tissue we need to repair. And that might actually lead the immune system the wrong way, to not attack. And, IL-6, obviously, it's problematic in some cases. And a lot of what we do, we actually give all the patients tocilizumab. We knock that down. So pretty much every time the patient's getting a procedure, they're actually getting, we even give it intravenously because it's, more systemic, issue. So, there are some stuff that obviously systemically is reasonable to give. And that's one, because the production can come from everywhere. So you want to knock it down globally. Same with TGF-beta. And TGF-beta, you can hit it locally, but you also need to knock it globally as well. Those are certainly, between IL-1, TGF-beta, and interleukin 6, those are clearly ones that, you would like to not only reduce in the tumor environment, but you want to reduce them globally in the patient. And so we do address that.
And we follow this on all of our patients. And I'm amazed, absolutely amazed how nobody else does this.
Yeah. They don't seem to catch it or understand what the importance of it. I mean, you look at it everywhere. I mean, you can research IL-1, you can research, TGF-beta. And I think any patient, if they have cancer, they should go look at associating IL-1, TGF-beta, cancer, then look at those things. And then they'll be like, holy cow, why is nobody, why is nobody else talking about this? These are big factors, and they're particularly regulating a lot of the myeloid part of the immune system, which you need to keep, to killing the cancer. And, it's important to block some of those things down. And that's what we do. I mean, we use drugs like anakinra, and obviously we have our TGF-beta blockers. And that's just something that I think that's the thing that really sets us apart from anybody else and allows us to be able to have great success when everybody else, they just can't do what we can do. I mean, it's
just another level of innovation. Really, it's just, there's no other way to describe that. And then, so the whole goal here, right, is to destroy parts of the cancer, not all of it, destroy parts of the tumor, stimulate, pro-inflammatory signaling, not too much, just the right amount, not create an anti-inflammatory, which, like you said, it helps to preserve that wound, cancer being called the wound that does not heal, helping to preserve that we want to actually not. Yeah. But it's the stimulation and the infiltration of additional immune cells. So, dendritic cells, natural killer cells, CD4 cells, CD8 cells, and PEF, excels at that.
Yeah.
I mean, excels.
Yeah. Yeah. I think, from a ablative technology, PEF seems to be superior. I think a lot of people are talking a lot about histotripsy right now.
Yeah.
Well, but here's the drawback. I mean, because I looked at it, I mean, I think it has some immune stimulating potential. Is it better than PEF? I doubt it. But the other thing is that this is external, so there's no needle, right? But the patient has to be kept still, so they have to be under general anesthesia. So that's a problem.
Suppresses the immune system. I mean, that has actually related to cancer.
Exactly. So you're not, and then you have no ability to put drugs into it. I mean, I got a needle in there. I don't put drugs. So that's why when, I talked with the company, Histiosonics, I think ago, and, cause they were saying, hey, maybe we should buy one of these systems. And I looked at it at first. I was like, yeah, it's interesting. But then I think it's like, no, but it offers us no advantage. I mean, we've got to get a needle in a tumor. That's the big advantage. And so, the other thing is that I can stick a needle in a tumor and treat the patient under, like a sedation but not general anesthesia, but do like propofol, which is actually less problematic. I mean, you can use anesthesia that's less, immune suppressive than general anesthesia, because that would be immune suppressive. And so you help manage your anesthesia better, and you could do it easier. It's safer. This is all safer. I mean, gosh, I don't know. This is way better. I just think it's better to stick a needle in a patient. Plus, you got to get the meds into the tumor. So,
this is a really interesting point, because you said there multiple times, immune system, immunotherapy, preserve the immune system. I was, just because, we're having a change of, administration in the United States and everything, RFK getting up there in terms of, potentially the Health and Human Services Director and everything, cabinet position. And so I got me going through the organizational chart for the National Cancer Institute. And I thought, oh, surely there's a department of immunotherapy or immune system.
Yeah. No, there's not. No, hopefully they can come in and try to fix a lot of things. We'll see what happens, but that definitely needs the whole sort of reworking of all of our healthcare.
Well, that shows that what is really driving and incentivizing the financial and research and really the structure of what comes to cancer therapies in the United States, immunotherapy is not even listed there.
Yeah.
And it's like, wow, that's out of date.
Yeah.
So RFK, if you're listening, first of all, you need to contact Dr. Jason Williams. But second of all, you need to add that department.
Yeah. Yeah. We, hopefully in the future we connect with them and give them some advice, because, there's a bunch of stuff that really needs to be changed all around in healthcare. And, I think that, clearly we need to be looking at preserving our immune function. I think that's the thing that's really detrimental to us all around. I mean, the reason that we get most diseases is because of that, because it's an immune system failure, and it's, people get cancer because of immune system failure. People get heart disease, immune system failure, hypertension, diabetes, all of that, all the diseases, everything you think of are because the immune system did not do its job for whatever reason, was inhibited. And so if we know the right ways to allow the immune system to do the job and make sure that we're not damaging it, and certainly, with certain medications, with certain, foods, things like that, disruption of the gut microbiome, also lack of certain, supplements or medications. I mean, I think that when we look at like vitamins, I mean, nobody questions, oh, you need vitamin A, B, C. Yeah, but maybe there's some other stuff that you kind of actually need that nobody's really talking about. And those are things that we should be looking at, and that I think we're missing. I think we start adding all that and making sure that, okay, it's not just those things. People need more stuff than that. Then I think we'll see people be a lot, healthier overall.
And, one of the things that, for example, when you look at PEF versus cryo versus radiofrequency ablation, of course, this study just looked at PEF versus radiofrequency ablation in the mouse model, was that the impact of that anti-inflammatory signaling of the radiofrequency ablation actually increased T-regulating cells and myeloid-derived suppressing cells within the tumor microenvironment.
Yeah.
And so those kind of, cells, tell the listener, what's the impact of those within the tumor microenvironment in and around the tumor?
Yeah. So some of these ablative technologies like that, may create this damage to the tissue, right? And then say you get these regulatory immune cells, these cells that are protecting cancer. And so now you've shifted the balance the wrong way. So you might have killed some cancer, but you've made the immune system want to protect the cancer more instead of attack it. Now, so you did the opposite. What you want to do is kill some cancer and make the immune system want to attack it. You don't want to kill cancer and make the immune system want to protect it. But that's what some of the, other ablation technologies may do and the way things are done. And this is obviously, radio frequency microwave ablation is probably the most common ablations done throughout the United States right now. Cryoablation obviously is probably mostly done incorrectly. So it's also problematic. I mean, if they're not doing it right. So unfortunately, we're doing all this ablation technology and we're not doing it the right way.
And then of course what happens is basically the sum of these two techniques as we just went through them is that one provides a significant stimulation of the abscopal effect, and the other provides a very limited, weak stimulation of the abscopal effect. So if somebody is listening there and they go, oh my gosh, what is my Scrabble word score with abscopal effect? I have no idea. But what is the abscopal effect and why is that important to the approach that you innovated and continue to innovate upon, that intratumoral ablation and immunotherapy?
Yeah, because I mean, again, it's a situation where you can do ablative technology that gets the immune system to see the cancer and attack the cancer, not just in that location, but in other locations everywhere, right? That's the abscopal effect is a distant effect. And so it's a systemic treatment. But if you do ablative technology the wrong way, where you create more regulatory cells and all that, well, you've created an opposite abscopal effect. You've actually now helping the immune system and watch what might happen. The other cancers probably go faster because now you've actually helped them, right? So that's what you'll see. And that's why when they look at these ablative technologies and the way they're doing it, they don't see these big survival benefits, right? Because it's the wrong way. They're not doing it right. If they did it right, they would have survival benefit. I mean, you would think, okay, why, if I kill some cancer, the patient should live longer, right? You should think. But why is it when I kill cancer the wrong way, the patient doesn't live longer? And that's what happens, right? They do this, they kill the cancer the wrong way, and then the immune system's now helping the cancer more. And so now you're speeding this stuff along. So you didn't do anything. I mean, you actually made it worse, technically.
Yeah, it comes down to an understanding of the immune system and really how it's activated, how its power is harnessed, and how it can be trained to then go after the tumor. Or, as you so eloquently stated there, Jason, how the immune system can actually be used to protect the tumor, preserve the tumor at the detriment of the body.
Yeah. I mean, you do the wrong thing, you actually mess stuff up. So people don't understand that sometimes there's stuff that you can do that you're doing it in the favor of the cancer. Yeah. You're not doing it in the favor. Yeah. A lot of people say, oh, strong immune system. Yeah, maybe, but which side? Because you strengthen the side that's protecting the cancer, which you could do in certain cases, right? There's certain stuff that, people think that, oh, this type of stuff is really helpful because like it strengthens these, there's been some drugs in the past where they looked at boosting macrophages and they're like, oh yeah, we're going to boost the macrophage. Well, wait, some of those macrophages are bad. I mean, some of those macrophages are working for the cancer. So do you really want to boost them? I mean, you want to boost the right ones, but you don't want to boost all of them. And so there's some stuff that's indiscriminate. And when you boost the immune cells, like some agents that we give to, like when they give chemo, and the white cells get knocked down and they give, stuff to stimulate the marrow to produce more, immune cells, more white cells. Some of that's producing more regulatory cells, more cells that are protecting the cancer. So you're replenishing, but not with the ones you want.
Well, you did a great job of transitioning there. So thank you very much. It's like your brother from a different mother, but, the macrophages and the neutrophils, you talked about, trying to stimulate the macrophages, but there are some that are good. Yeah. And there are some that are bad. And these different ablative techniques, same thing with the neutrophils, N1, N2, M1, M2.
All of them.
Tell the listeners here, what's the difference of M1, M2 macrophages? And that basically extrapolates to neutrophils, but what's the difference of them and why is that important in the stimulation of the immune system?
Yeah. So basically the thing is that you think of the immune system and you can see it as everything you can imagine. it can be eosinophils, monocytes. Everything has either a regulatory or an effector. So it can either protect cancer or attack cancer. I always think of that Superman movie where they had the Superman and they had the bad Superman. He was like, looked the same, but he was slightly like different, right? Slightly a different color. The immune system has the same thing, right? It's that that other sort of, alter bad side of it. And so, and guess what? They function the same way. The bad side likes certain interleukins, it likes certain drugs, like certain stuff that boost it, right? So how do you differentiate the two? What is the one is the bad one? Does it also not like kryptonite? Or maybe it's a different thing, right? Maybe it's another substance, right? so, and then that's kind of what you have to find on that. You have to find what is the stuff that those particular things don't like, but the others are okay with. How do you shift the balance, or how do you convert the ones? That's the other thing is like, you can convert them because they're that way because they're receiving signals, but if they receive other signals, they might switch sides. And so you can change some of those. And so, so there's a lot of real specific ways. I mean, real interesting stuff. I mean, I think, when you look at like the, macrophages and all that and certain signals there, like certain genetic signals that'll flip it from, what we call the M1, M2, being M1 tumor, one is attacking and two is the protecting a cancer. So, and yeah, there are some interesting ways that you can kind of manipulate that. And it's also we know we do it. We do this. We work with various drugs, trying to tip that balance in the favor.
Well, you don't have to do it with drugs. This study that I mentioned, again, check out the show notes. It actually showed that ablative techniques can stimulate that. So, for example, the pulse electric field via the interferon gamma and interleukin 12 promotes the M1 polarization, so a shift, but it also decreased M2 macrophages because it actually decreased IL-10 and TGF-beta, but the radiofrequency ablation did just the opposite.
Yeah.
And then when you look, so it was promoting M2, whereas PEF is promoting M1. And really interesting when you look at it related to cryo, of course, not in this study, but outside that and other research, cryo initially does a good job of stimulating the M1, but it then can cause a shift to M2. And so there's a very interesting, potential problem with cryo that doesn't seem to exist with PEF that clearly doesn't, just the counter is in radiofrequency. One is stimulating the immune system that's going to target the cancer. One may do that for a short time and then reverse that to actually check. And the other one just protects the cancer.
Yeah. Yeah. The cryoablation is very operator dependent in what you do, and particularly volume. I mean, like, I think you want to be immune stimulating, just do a small volume. So we did in our clinical trials. I mean, just do like a, 1 centimeter ice ball. The reason that we chose for clinical trials, cryo is just because of the availability. So, would we like to do pulse field? I'm sure, would be nice in the future. I'm sure that would be the direction that we could go. But, at the time, cryo was what we had to choose. And so, but you can make it work by doing it consistently, right? Like the small amount that will help. So, but unfortunately, that's not what the doctors do. I mean, when the radiologist or surgeons, whoever's doing the cryoablation goes in there and be like, I've got this 4 centimeter tumor. I'm going to put like 6 centimeter ice all around it. I'm going to kill the tumor and all the tissue around it. They're going to think they're doing such a great job, but they didn't, right? They just really screwed everything up. So
I was trying to, look at the neutrophils, and because they, like you said, every type of white cells can have a, type 1, type 2, one that targets, one that protects. The only research I could find looking at the ablative techniques related to the neutrophil different types was actually simply look at ablation. And this was interesting because it would actually stimulate, interleukin 1 and, interleukin 1 beta, actually helping to create a N2 dominance, creating an immunosuppressive environment and actually stimulate neutrophil extracellular traps. So,
yeah,
so when you look at that, it's like,
yeah.
So it's things there.
So yeah, so I can tell you in my experience in studying cryo and how you make it immune stimulating, is a few ways. I mean, one is that you can inject, TGF beta inhibitor into the tumor site, or give it, or you could give a TGF beta inhibitor systemically if you wanted. Then the other is you can inject IL-1 blocker anakinra into the tumor site. That's, another way to kind of boost that response. And then the other one that really also moves the needle a lot is a CSF1R inhibitor. Plexidartinib is the FDA approved version. That was real hard to get because the thing is, it comes in pills. If you want an injectable form, that's a whole other deal, right? But plexidartinib, and it's super expensive. Obviously won't be covered by insurance, off label, but, adding that because CSF1R has a effect on the macrophages. And so you do that will convert cryoablation to now be immune stimulating. That's sort of your minimum base, that if you're going to do cryoablation, you should do that at least to make it immune stimulating, if nothing else.
And that's actually what that study talking about cryo and the shift of the macrophage and neutrophils was talking about. It was saying you need to do, additional therapy to basically target the immune system with the ablation. And that is actually a perfect summary of what you just said.
I haven't even read the article, so it's interesting. But I know we've done all this stuff. We've looked at it. We've seen it in humans, and we know it. So we know what needs to be done. And I think to me, ablation alone without injection of any drug is a real big mistake. That's just my opinion. I just don't, I don't even see why you would ever do that. I mean, it's just crazy that you're going to ablate somebody, but you're not going to put some darn drugs in there. I mean, you could at least put some damn lidocaine in it. I mean, like, that at least like help out some. I mean, gosh, I mean, something middle, but lidocaine and Toradol, I mean, that's easy enough. Yeah. I mean, there's a couple, mild things that you could get that.
But I suspect that what they would do, they'd probably inject Tylenol.
That they might.
Yeah, probably what they would do.
Your steroids, right, or something like that. Yeah, the stuff that might actually not work.
Yeah, that's right. Well, Jason, obviously, I think we've highlighted in here how you continue to lead the innovation front at the Williams Cancer Institute in North America and really around the world. Yeah, because innovation is just in your blood. Where is the Williams Cancer Institute going next? Innovation's ongoing. Is there any insight there to what innovation people might be, teasing their ears to hear about in the future?
Yeah, well, obviously, we're just trying to expand a little more on what stuff can we inject into the tumors to gain a little more ground, but also we're trying to be cost conscious because, the problem with some of these drugs is the expense. And I don't think the patients really have a good idea about this. I'm going to tell you because I tried to buy a drug the other day and I looked at the price on this. Now, so there's a FDA approved drug for interleukin 15, right? So interleukin 15, great option to inject into the tumor. I mean, that's certainly, you could add that and there'd be great cases that you could do it. So we like to have that. We like to have those things in our arsenal, right? We like to have various ones that we could do. So I was going to order some of it. So it's $38,000 for 400 micrograms. Okay. So yeah. Now, so that's a single dose, $38,000. Now, a lot of times we buy our drugs, we buy like these other like monoclonals and stuff. We buy them in gram qualities, because the systemic dosing can easily be 500 milligrams or whatever. But so we'll at least try to buy them in grams, which can be, those are $40,000-$50,000 a gram is what the other monoclonals run, right? That's typical. I don't think patients understand that. I mean, you buy Yervoy, it's, 200 milligrams is in the US, $34,000. So right. So, I mean, we're injecting multiple combinations of drugs in the patients as it gets like pretty expensive. But I just tried to figure this out. 400 micrograms, that is $95 million per gram. I was like, wow. I was like, that's crazy. That's an FDA approved drug. That's FDA approved.
Hello, Elon Musk.
Yeah. I was like, I think it's like, gosh, I don't know, but obviously we're going to get some where we use it. We use like various things where, we've used some IL-12 before, and, I know that's the thing. You look at like some of the options on these, but I don't know. We'll figure it out. But the drug costs certainly are, problematic on these things. I mean, these drugs are super expensive, and, we have to buy them from other people. We're not like, we have our drug development in that part, and that does help in certain situations where, we're able, I mean, I don't know, patients could never do what we do. I mean, like they could never, if they went somewhere else to try to get the same treatment in the US, it would be millions and millions of dollars. It'd be impossible to do.
Yeah. So if somebody's listening that have cancer, a loved one that has cancer, where can they find out more information about you, the work that we do at the Williams Cancer Institute?
Sure. Yeah. So we have our website, williamscancerinstitute.com. Certainly, I think, a lot of patients, if they're really going to check us out, they should check out my book, The Immunotherapy Revolution. Working on another book right now, but even that book is older. It actually now is all the things that people are talking about currently. Well, I wrote it wrote it actually longer, but came out 5 years ago. Nobody was talking about that stuff. Now people are talking about it. Back then, I don't know if people just didn't even, I guess they just ignored the book, right? I don't know what they thought. I mean, gut microbiome, all this other stuff. They're like, what's this book talking about? And now they look at, oh yeah, this makes sense. Yeah. But, 5 years ago, I guess it was like, something else, but it hasn't changed. So I just wrote it ahead of time, and that's, like we go to, various meetings, and, colleagues and stuff who read the book. They're like, they'll see the presentations coming out, talking about things that we talk about, like, sitagliptin, DPP4 inhibitor, improving immunotherapies, propranolol, all these other things that now, people are talking about, and they're like, hey, that was in your book. And so people are like, hey, where was your time machine? How did you like go in the future and see that? But I mean, we saw the research coming and knew, what was coming along. And I mean, we just adopt this stuff early. Most doctors, the medicine that doctors that you go to top centers, and I talk to these doctors. It just blows my mind. You could go, Sloan Kettering, MD Anderson. The medicine they're priced is 30 years old.
Oh yeah. Yeah.
I mean, it's like really crazy. And that's like current.
Well, there's no incentive to innovate, Jason. I mean, yeah. And that's what it's just in your blood. And so if you're a patient with cancer, if you have a family member, a loved one, or friend with cancer, and you want to learn about the innovation at the Williams Cancer Institute, as Dr. Williams said, williamscancerinstitute.com. You'll find his book there as well. And of course, you can find Williams Cancer Institute all over social media. And even they can find you on social media, correct?
Yeah. Yeah. We post a lot of stuff. I mean, I try to, I see interesting stuff. I obviously have people that handle like all my social media. I don't really get into it myself. I don't really deal with the stuff, but like when I see something interesting, hey, you should put this out there. That's right.
Well, Jason, thanks again for joining the podcast, and thanks for bringing, your insights, your expertise to the innovation here of, intratumoral ablative techniques, but really you expanded it beyond that. So you never disappoint. Thanks again. And I can't wait to see where we're headed.